My name is Jezmir. I'm the Chief Medical Officer at AristaMD. I'm a primary care physician myself, and my background is in value-based care delivery, working with both health plans and provider groups such as Blue Shield of California and Atrius and Concerto Care and a few others. I am really excited to discuss Specialty Care 360 together and the way that this model can really help support providers and patients in getting the care that patients need in a timely and high quality way. So please feel free to add questions to the chat. Happy to discuss and make this interactive as well. And so with that, let's go to the agenda. Our goals for today are to review Specialty Care 360 and what are the services that are included in this type of model, and how can we work together to make this model meet the needs of your patients. So the way that we think about Specialty Care 360 is that it is a suite of services which are all modular, and they can all be mixed and matched according to what your organization is trying to solve for and what are the needs for your patients. The first is care delivery. This includes the entire continuum of care for your patients in several specific specialties, and this includes eConsults, virtual telemedicine visits with specialists, and navigation to in-person care. The second is care support, and this is the care coordination component of having our team help patients and making sure that they get access to the right care at the right time in the right place, and if they need testing or imaging to help set that up and make sure that they are able to get the right care. It also includes coordination between specialists and PCPs. And of course, my favorite is the health coaching and helping patients meet their care goals. The third is care design. This includes developing care pathways, again, according to the specific patient needs, and building out various programs around health coaching or care transitions or other types of programs. And finally, we have performance oversight, and this includes the analytics, both for proactively identifying patients who need care, as well as the monitoring and evaluation to ensure that the program is working in collaboration with our partners. We monitor metrics such as engagement, population health metrics, total cost of care, and patient and provider satisfaction. Now, why did we build this program? The reason for this is that many organizations, and I imagine that you've seen this in your own organizations, is that many folks face really significant challenges when it comes to access to specialty care. In many places, it can take anywhere from 2 to 6 months to get a specialty care appointment, and patients are disappointed by the delays. PCPs don't know how to help or have any other options, and oftentimes, as I'm sure you have seen, the patient's condition may worsen and the patient may end up in the hospital. They may end up in a worse state than they needed to be. And all of this can be addressed earlier if they're able to get the care that they need. And of course, this all leads to higher cost over time as well. And so our solution, again, through the care delivery, care support, care design, and performance oversight, seeks to target those problems. Now, we've designed this program to be modular, so the 4 components can be mixed and matched, again, according to what the organization needs. Many of the organizations we work with are risk-bearing primary care groups. We also work with ACOs, integrated delivery networks, and employers. And the baseline components of those 4 that we talked about are all very similar, but then they can be mixed and matched or modified in a way that helps meet the context of the particular organization. So why do all these groups want these services or need these combination of services? And this very much goes back to access and cost challenges. Specialty care is really important, but can be very difficult to access. whether it's in a rural area where there are few providers or in a major metro area because demand is so great. And we all know that we have specialty shortages, and sometimes we have network adequacy issues if a specialist isn't covered by your insurance. And so this really significantly limits the speed with which the patient can get to the specialist, as well as if they can, the specialists themselves, if we're able to reach them. This, of course, leads to delays in care, and patients, again, may get worse while they're waiting. PCPs I'm a PCP myself, and so we try to do as much as possible, but if there's a 3-month wait to see the cardiologist, or for many of our partners, a 4 to 6 month wait to see a rheumatologist, there's only so far that you can go without a specialist helping guide the care. I think I myself have been very disappointed when I have a patient who ends up in the hospital because it's worse for them, worse for us, and there's a lot that we could have done to help address that. The other part of this is that we know that virtual solutions are very effective, and not all of us have the availability for them, or if they're not integrated into the way that we practice, then the patient goes off on their own and we never hear about it afterward. And so that limits the care coordination, and the patient has to deal with a fragmented system themselves. And finally, it's the cost. And so whether this is the patient has to go to an out-of-network specialist, or there's a lot of, again, with the absence of the coordination and communication, if we're doing a lot of duplicate testing and such. So on the next slide, I want to walk through what does an example of Specialty Care 360, what does this actually look like? We talked through the challenges, we talked through the basics of the design, but here we have, let's put it into an example and into perspective. So we have a group, this is a fictional group, it's called Acme Health. It is a risk-bearing primary care group, takes care of about 100,000 patients, and they have 1,200 participating providers, 7 hospitals, and a number of outpatient clinics and urgent care centers. Now, Acme's challenge, as with many of us, is that it is very hard to get a patient an appointment because there are such significant specialty shortages. It's hard to find somebody who's a network. The patient has to wait for a long time. And patients who do get an appointment, again, are often out of network, which increases the cost and the duplication of services, the absence of care coordination. And I know that whenever I refer somebody out to in-person care, I love it. They often get great care, and I never hear about it. And then the patient comes back and is shocked that I don't know what's going on, and it causes additional frustration. And like we talked about before, we all know about fragmentation in the system, and it's really hard for patients, especially when they're sick, to navigate those challenges themselves. So what could this look, or let's put this into more perspective of having our patient Mark. So Mark is a phenomenal guy. He's 62 years old, and he comes to his PCP. And Mark is a guy who he loves history books, he loves his kids, he has multiple comorbidities. He also has, and on today's visit, he presents with shortness of breath and ankle and leg swelling. Again, he has multiple comorbidities. We know he has hypertension as well, and that's been managed by Dr. Smith, and he's on losartan and amlodipine and antacid and multivitamins. So he comes in, sees Dr. Smith. Dr. Smith addresses his condition and his symptoms and orders a few tests, gets an EKG, and strongly suspects that Mark has congestive heart failure. She decides to refer him to a cardiologist in person because he has, again, the multiple comorbidities and a challenging case. And so she wants someone to help with the entire initial workup to make sure we don't miss anything. However, it's 8 weeks until Mark can get an appointment. So we go on here. Oh, nope, here we are. So what can this look like for somebody like Mark if there's an alternative solution? And so now we're going to go through the case of Mark and go through the 4 different components that we had talked about. So starting with care delivery, it is a good thing that ACME has deployed a specialty care 360 model. And there are a range of different ways that Dr. Smith can help Mark access care. The entire model that we have, it seeks to keep the primary care provider very much at the center of care, and we are the extended care team. And again, that's because the cardiology condition does not live alone without the context of everything else that's going on, and the PCP is very much the quarterback. And the specialty care teams that we have are designed to help support the PCP in delivering care. So instead of waiting for 8 weeks for Mark to get that appointment, Dr. Smith refers him over to Specialty Care 360. And from here is where he gets triaged to the appropriate care modality. Again, we take on the entire continuum of care. So starting with eConsults, which are peer-to-peer, specialist to patient, or specialist to PCP. So, and we'll go through those in detail as well. The second is video or telemedicine consults, and here it is direct specialist to patient, and so they have a conversation. This is for folks who need more direct specialist interaction, but may not need in-person care. And then finally, some patients will need in-person care, such as if they have a need for a procedure or if they have more complicated care that needs in-person support, and then we will help navigate the patient there. So looking at a little bit more of a breakdown of these different modalities, all of them are according to the complexity of what the patient may need and their clinical case. The first is an eConsult. This, again, is a peer-to-peer. PCP submits the patient's case over to our specialists, and we review, and the specialist returns recommendations, and the PCP can follow up directly with the patient. What we see in our eConsult model is that we have a 73% referral avoidance rate, which means that for 73% of cases that we receive, the PCP gets enough information or gets the right information that they need to take care of the patient in-house without referring the patient out. Again, this is you get the recommendations back within just a few hours and can get the patient the care that they need. Now, let's say that Mark, using Mark's example, let's say he had long-standing heart failure. We know that he had diastolic heart failure, and some of his medications, he was having trouble with them, and so he needed help with the titration. He was retaining more fluid, getting a little bit more short of breath, and so the consult could be for assessing if there was like the cause of the exacerbation, as well as how to titrate his medication. That is a great case for an eConsult. Now, the second level and the second modality is video consults or telemedicine. Now, this is for slightly more complex cases and for patients who need to directly interact with the specialist. So, for example, in Mark's case, as we just talked about, it's a new heart failure. It requires a full workup, more history, more testing, and more follow-up. And especially getting him on goal-directed medical therapy, telemedicine is a great way to go for him. And then finally, for in-person care, this is for patients who, excuse me, this is for patients who have even more complicated cases. Let's say he had an ejection fraction of less than 15%. That's an in-person case. Or let's say that he had worsening chest pain and needed to get a stress test or get an angiogram. That would be an in-person level of care. And we would help navigate him to the right specialist and make sure that he got an appointment and follow up and got on the right care plan. So in our model, every patient has either an eConsult or a video visit to start. And sometimes eConsults get turned into video or telemedicine visits. And again, for those who do need in-person, because they've already seen a cardiologist, they come equipped with an entire package of information, the initial workup, the initial medication titration or whatever else it is that they may need, so that even if they are waiting for 8 weeks to get an appointment, this is an opportunity to start them on their care journey and really help expedite the time that it takes to get them on the right care plan. All right, so moving on to care support. We talked about how we manage care delivery, but care support is the behind the scenes work. This is with our care coordinators, and they help curate all of the information. They do a lot of the health coaching, and they really are there to help the patient, to help them on the continuum and the entire journey, because when you're sick, it's hard to manage all of this, and having someone who's there to help you is what care support is all about. For us, this starts with compiling and reviewing the records, which is surprisingly challenging, but ensuring that the specialists have all the information that they need and that we communicate back with the PCP, again, to keep the PCP very much at the center and help support them in being the quarterback for the patient's care. Then we go on to determining the best care setting. Our care coordinators and care managers work with our specialists to evaluate and triage to the right care modality. For coordinating treatments, here we have, the care coordinators helping with the patient. If they need any testing, let's say this patient for Mark, he needed an echo and labs, making sure that he's able to get those, that everything is scheduled, that he has transportation, and that he's moving along on this journey. And when he has the care plan set and he started on his goal-directed medical therapy, then he has some good health coaching, so he understands what the medications are, how to take them, what to watch for, and what red flags he should look for, and when to call for help. This also helps with identifying upfront any exacerbations, or if the care plan isn't working, so we can get that information back to the specialist and facilitate additional follow-up as needed for him, so that he is able to go back to his kids and his history books and all the other things that happen in daily life. We know that most of care happens between appointments, or most of health happens between appointments, and so our care coordinators are there as a point of contact to help the patient maintain their health. Finally, we have the monitoring of the patient, again, making sure that that the patient is on track, and then getting the information back to the PCP so that they are fully engaged and can continue managing the care for the patient. All right, then we have, here we go, care design. Now, this is how we structure the elements of the program. Again, we work together with our partners to really define and identify the frameworks that work best for their models and for the patients, and what they're looking to solve for. So for example, in care pathways, we will help identify and stand up specific workflows and evidence-based care pathways, such as if a patient has a hemoglobin of A1C of over 9, that triggers a care pathway and helps get a patient enrolled in care. If they have a hemoglobin A1C greater than 9, we know that something is going on and that they do need this extra support. And again, we'll work with the primary care provider to get the patient into care. Other examples of this are if the patient had a recent COPD hospitalization, if they have worsening, if they've been, again, CHF, let's say they've had an exacerbation, that further triggers getting into a pathway. In addition, we define together the patient intervention. And so this includes both proactive care and reactive care. So for example, on the proactive side, we evaluate claims data and EHR data to help identify which patients may have gaps or may need additional support. We're also helping with navigation so that when a patient does need specialty care and they do need some follow-up or labs or imaging or some additional coordination or coaching, that we are there to help support that care so that they don't get lost in the shuffle, and always have somebody who's looking out for them. And finally, we really focus on care transitions. We know that this is in the exacerbations and in the immediate period afterward. This is the point where patients are most vulnerable. And so we have programs that we can deploy in collaboration with our primary care groups as to making sure that the patient is back on track and doesn't need to head back to the hospital. All right, finally, we have performance oversight, and we've spoken about this a little bit, but this is the analytics for both the proactive care as well as the monitoring and evaluation of how the program is doing. For proactive care, we look at EHR data, we look at claims data, and again, we identify folks who do need support, especially if they have uncontrolled chronic disease. So again, we talked about the hemoglobin A1C over 9, or if a patient is on oxygen, or any of a number of other, or if a patient just continuously is getting referred to specialty care, or if they're in and out of the hospital, this is an opportunity to help move upstream and be more proactive in collaboration with primary care in getting them additional support, whether that is through eConsults or video visits or engagement of our care coordinators. Then the second thing we do is we monitor on an individual patient level. So is the patient getting the care they need? Are they able to make their appointments? Are they getting their medications? Are they getting their labs and imaging? Are we keeping them out of the hospital? And most importantly, are they feeling better? Are we actually getting to the goal of what we're trying to do? And then finally, we're looking at the big picture population health metrics. Are outcomes better? Is utilization of unnecessary labs and imaging and procedures, are we helping to reduce those? Are hospitalizations down because patients don't need them? And overall, are we achieving lower costs for specialty services? And often, which is driven because telemedicine is a lower cost modality, and we're following, making sure to, as described in our care design, to follow evidence-based pathways for our patients while making sure to meet their goals. All right, so we went through the 4 different components. And so finally, I want to take us through what this looks like for a patient. So let's go back to Mark. So Mark starts off and he gets referred to the program. And the first part that we start with is the care design. So this, again, based off of the evidence-based care pathways, we know that with a new heart failure, that's going to go on, his case is going to go on to virtual care. Then we have care support. Our nurse manager reviews the chart, pulls all the necessary information, gets the patient an appointment, and then our care coordinators will connect with the patient and then do the initial intake, make sure that all the technology is working, make sure that any issues until the patient can be seen are addressed, and really starts to understand what the patient's goals are and what they're worried about, what Mark's worried about, what Mark is looking for, and how we can best help Mark. Then we go to number 4, where we have care delivery. And here Mark sees a cardiologist. They do a telemedicine visit. The cardiologist orders an echo and another set of labs. And then after that visit, our care coordinator team will follow up with the PCP, make sure that they have the information, will help Mark schedule the echo, get the echo, and make sure that the results go back to the cardiologist. Once the cardiologist has the results, we go back to care delivery, and here we have another visit for Mark with the cardiologist where they review what's going on. Mark has diastolic heart failure, and they discuss the care plan. Mark gets started on guideline-directed medical therapy and starts his journey. And the care support piece, again, our care coordinator follows up with him, makes sure that he gets his prescriptions, gets the medications, knows how to take them, knows not to eat too much salt, knows when to call, and most importantly, they're there it's a new diagnosis, or even if it's not new, if it's a chronic disease, these are tough things to manage, and oftentimes folks need somebody to to help. And that's what we're there for. It's also an opportunity to identify when the patient is, maybe the treatment plan isn't working. And so the specialist needs to know, or maybe that there's an exacerbation or something is happening. And so this is a link back to the specialist, and the specialist and the care coordination team work very much in tandem to support patients. And finally, we get to performance oversight, again, making sure that things are going well for Mark, and also looking at a population level, making sure that we achieve the outcomes that we are working towards together, helping the patient feel better, reducing exacerbations, and reducing cost for the patient and for the group.